Good morning, good afternoon, and good evening to you all. Thank you for joining this webinar today. I think people are still coming in, but in the interest of time and this very important topic, we're going to get started. One housekeeping announcement. Please feel free to share any questions or comments using the Q&A button at the bottom of your Zoom screen throughout this webinar. My name is Muka Chikuba-McLeod, President and CEO of JSI. I have the honor today of moderating our webinar featuring a distinguished panel of experts in HIV. Personally, I have been working in HIV my whole professional life. That is 34 plus years now. I recall working as a newly qualified medical doctor in the early days of the HIV epidemic before HIV treatment became widely available. So many lives lost. I, like many of you, have seen the transformative impact of effective HIV treatment, care, and prevention, and I am so grateful for the progress we've made. And I'm so hopeful that a future where HIV is no longer a public health threat is possible. We at JSI recognize that HIV care and health systems can be improved by integrating services for better coordinated and simpler person-centered care. The how and what of integration of HIV services into primary health care is what we are going to tap into the collective wisdom and knowledge of our panel of experts to learn today. JSI defines HIV integration as managing and delivering health services together and equipping and leveraging the health system to enable this intersectional service provision. We view HIV integration as a person-centered approach where proactive care, including health promotion, disease prevention, diagnosis, and treatment, is delivered by multidisciplinary teams, or sometimes, let's be real, by one or two multi-skilled providers working in a small rural health clinic, but as close as possible to where people's everyday environments are and reducing morbidity and mortality across the lifespan. Integrating HIV services into primary health care is a crucial step towards making care more accessible and sustainable. I saw this through JSI's work in Zambia through the USAID-funded Discover Health project, a project that dramatically increased access to HIV prevention, care, and treatment services at the lowest level of the health system in Zambia, which is the health post, in both urban and rural settings. This project not only achieved high viral load coverage and suppression rates among children and adults, but it also revitalized these primary healthcare structures, transforming them from first aid stations to bustling community-based primary care clinics. Integration of HIV into primary care settings must be approached with care and nuance. Each community faces unique challenges shaped by their local epidemic, health system capacity, and other socioeconomic and environmental conditions. To ensure quality and effectiveness, integration must be tailored to these contexts, strengthening health systems while safeguarding client rights to access, choice, and confidentiality. Charting the path to sustainable integrated care is an enormous task. So I am honored to welcome an esteemed panel that can help us think through how we can craft person-centered integration that meets the urgent needs of today while building toward long-term improved health outcomes. First, I would like to introduce Ms. Beatrice Ajonye, the Uganda National Coordinator for the Community-Led Monitoring Project from the International Community of Women Living with HIV, Eastern Africa. ICW is the only international network run for and by women and girls living with HIV. It was founded in response to the desperate lack of support, information, and services available to women and girls living with HIV and their need to influence and input on policy development. Next, we have Dr. Deborah Goldstein. She is an infectious disease physician and medical officer at the U.S. Agency for International Development's Office of HIV and AIDS. She focuses on issues of HIV and primary healthcare integration, non-communicable diseases, HIV and aging, and HIV drug resistance, in addition to providing country support. Prior to joining USAID, Deborah spent over a decade at a community health center in Washington, D.C., practicing integrated HIV and primary care medicine and doing HIV clinical research. Next, we have Dr. Njeri Kamere, who is the Managing Director of the Health System Division at the Aurum Health Institute in South Africa. A versatile clinician specializing in both HIV-related public health and ophthalmology, she has managed large and complex donor-funded programs across low and middle-income countries, including Kenya and South Africa. We also have Ms. Rose Nyirenda, the National Director for the HIV, Sexually Transmitted Infections, and Viral Hepatitis Program at the Ministry of Health in Malawi. She is a community health and multidisciplinary care specialist with extensive experience in health policy, strategy, and technical guidance for community health, HIV prevention, care and treatment, sexual and reproductive health, and maternal and child health. She's an expert in design and management of health systems and health services. And lastly, but not least, I have the only boy on the panel. I'm pleased to welcome Dr. Yogan Pillay, currently leading the Bill and Melinda Gates Foundation efforts to strengthen TB and HIV program delivery. Yogan was previously the country director at the Clinton Health Access Initiative in South Africa. He also served as Senior Director for Universal Health Coverage and as Deputy Director General of Health in South Africa's Department of Health. He is a leader in the global fight against TB and leads the Gates Foundation's Africa Working Group on HIV. I am going to ask a select group of panelists to answer a given question so that we have time for a robust discussion at the end. Please feel free to add any questions or comments using the Q&A function on your Zoom screen throughout this webinar. To kick us off, I will ask our panelists to lay the groundwork for this discussion on integration. Let us fast forward to 2030 and imagine that HIV services have been fully integrated and are part of the primary care service package. What does that look like from each of your perspectives? Deborah, could you please start us off by helping us think through the different models of integration? Then we'll go to Yogan and then we'll go to Rose. Deborah?
Thank you for having me, Muka, and for this opportunity to offer some brief framing around the phrase HIV integration and what it means to us. I think of HIV integration as being composed of several different components. One is partial program integration, which is when two or more services are delivered in the same place by the same staff, but not as part of a comprehensive package of care. So here the HIV platform is leveraged so that non-HIV services are added to the ART clinic, or HIV services are added to non-HIV services. Some examples would be community health workers providing HIV and mental health screening together, or ART clinicians providing HIV services and hypertension treatment together, or HIV testing and counseling provided in the outpatient department. But HIV integration can also mean fully integrated HIV services within primary healthcare. where all primary healthcare and ART services are available at the same place, at the same time, by the same provider. This model offers HIV services as part of a comprehensive, holistic care package with health promotion, disease prevention, diagnosis, and treatment for a whole person-centered approach. And there are also several hybrid approaches that have been well published. I would call these longitudinal chronic care clinics, where hypertension, diabetes, and HIV are provided in a single setting for people often with and without HIV. So the right model for integrated HIV services is context dependent. I think there's broad agreement on that, where underlying primary healthcare systems are strong. Integrating HIV into primary healthcare brings needed resources and strengthens the overall health system. And where underlying health systems are weaker, maybe a lack of commodities or a lack of training or space constraints, or underpaid, understaffed healthcare workers, integrating non-HIV services into HIV care might make more sense, or creating chronic care clinics for stable clients with HIV, hypertension, diabetes might make more sense. Thanks so much.
Thank you, Deborah, for that insightful framing about integration and how important the context is and the state of the health system as well is. Yogan, what does a primary care service package that has integrated HIV services look like in 2030?
Okay, thanks very much. And again, thanks to JSI for inviting me onto this panel. You know, if I look back, if it's 2030, I would like to see that we did the right things with respect to sustainability, sustaining the HIV response in the context of strengthening primary health care and in the context of universal health services. So what we need to do, of course, and now, so that when we look back in 2030, we can say we did the right thing, is to ensure that HIV services, where they are needed, where the burden is high, has been integrated into the primary health care package of services. And this will mean, of course, everything from preventative services. We don't have a cure, so it's treatment services, as well as, proper case holding. I think the one thing we need to remember as part of primary healthcare and integrating HIV into primary healthcare is that the HIV cohort is currently aging and because people are living longer, they are aging, so they have all manner of other chronic diseases. So integrating HIV into other chronic diseases is going to be particularly important now and as we look back from 2030. The other reason to integrate, besides sustainability, is what we've called transition from donor-funded HIV programs to country-led, country-financed programs. So we need to think about, and I'm sure Rose will speak a lot about this, we need to think about, what does this mean in terms of health financing writ large, and not just financing the HIV program, as well as what it would take to ensure that we provide the services, the primary healthcare services, including HIV, in ways that meet the needs of populations in their different contexts. And I think, we do need a different health service delivery model, which includes HIV and TB and amongst other diseases, that does not wait for patients to fall ill before they can come to a facility, which might be quite far away, to receive care from under-resourced services. So we need to rethink the primary healthcare delivery model. And I think the HIV programs, as they are currently constituted, provide a good basis for how we should reorientate primary healthcare, with respect to, for example, task shifting or task sharing, with respect to community-based services, with respect to couriering drugs to patients, with respect to using home-based services, like HIV self-testing, and we can do that with a number of other illnesses. So, we need to rethink the way in which we deliver primary healthcare, and my view is that by integrating HIV, primary healthcare will benefit. Thanks. Over.
Thank you, Yogan. Most certainly, by integration, we are moving the needle forward on the issue of sustainability, because health financing for all conditions, including HIV, is going to be increasingly important for countries as they begin to take on the responsibility of providing care, not only for HIV, but for all the other health conditions. Thank you for that framing. And Rose, what is your vision for an integrated HIV program in 2030 Malawi?
Thank you once again for allowing Malawi to share its story, which is integrated to the topic under discussion. So the vision that Malawi has, I think I'm going to talk about it, to explain about or to respond to this question based on Malawi's vision, because we have already started unpacking what this vision will look like. So our vision is that of an HIV client who is at risk or who is already living with HIV, can receive essential package of services at a point of contact with a healthcare provider at primary level. And this means that HIV is integrated within the broader health system, focusing on primary healthcare, but also focusing on community-based models. We are looking at HIV prevention, care and treatment delivered alongside the essential, what we are calling in Malawi, the essential benefits package. So what Malawi has done is to come up with the basic package that everybody should be receiving or may need based on the healthy condition priorities. And our essential health package comprises of HIV, TB, maternal newborn child health, malaria, and NCDs. So we are looking at a client who would walk into primary health care facility, will be determined if they are at risk and they receive all the services. And if they are already living with HIV, they also receive the package of services that are required. If they have an NCD, then they are attended. And equally, if they need family planning, cervical cancer screening, all that is done. And that also requires that if the client requires that they are linked to another level or layer of services, then they can be referred accordingly. So they can be referred from the community to the facility, or even from the facility to the community. And the models of care at the community will also be adapted to address the needs of the populations. For example, we are already looking at having community models that will address problems that adolescent girls and young women experience and their partners, but also ones whereby key population, those ones that will be adapted to meet the needs of key populations. So that's what we are envisioning in the immediate, because we have already started even unpacking some of these areas and even the future. Thank you.
Thank you so much, Rose. It's great to hear that your vision includes an essential benefits package delivered at the primary care level at the point of contact for the client, but also includes appropriate referral, because that's going to be important for additional care when that is required. So we've heard from some of our panelists what a future with an integrated HIV program will look like, between full integration with primary health care, like the vision that Rose described for Malawi, and partial or hybrid approaches, as Deborah described it. But they all have shared underlying values and goals, strong health systems appropriate to their context that promote client access, choice, and well-being. Now, some countries and communities are close to that vision, while for others, there are gaps and a way to go. Deborah, I know you've published on this topic a lot. Can you tell us from the evidence base what will get us there?
Sure. Thank you. So we often hear that there's not enough published evidence that HIV integration works, but that's not the case. And I'm just going to take a few minutes just to run through the strongest evidentiary support for these models. So the largest meta-analysis and systematic review on this topic is from Caroline Bolstra and colleagues, and it was published in 2021 in PLOS Medicine. They identified 114 studies of partial program integration, and 90 of these were from sub-Saharan Africa. And this was mostly looking at family planning, maternal child health, and TB integration into ART clinic, or HIV testing integration into non-HIV services. And what they found in the meta-analysis was that integrated services improved HIV outcomes. They had improved uptake of HIV testing and counseling. They had an increased ART initiation, decreased time to ART initiation, improved retention and care, increased viral suppression. And the costs of basic HIV and non-HIV services tended to be lower in integrated programs. There are also well-publicized longitudinal studies that I alluded to earlier of integrated chronic disease clinics for people with HIV, with hypertension and diabetes, and you've probably heard of these. The SEARCH study in Kenya and Uganda, INTE Africa in Uganda and Tanzania, and South Africa's integrated chronic disease model. And these have shown collectively decreased HIV incidence, decreased HIV stigma, increased uptake of HIV services as a result, a high retention in HIV care, and improved population level virologic suppression, as well as decreased mortality among people with and without HIV compared to people receiving care in non-integrated siloed clinics. So the last piece of this, I think, is what is the data to support the fully integrated HIV services within primary healthcare model? And we'll share, I think, the best piece of data, which came out this summer from Priscilla Pinto and colleagues in PLOS Medicine. And this is an 8-year retrospective cohort study of almost 3.5 million low-income Brazilian people receiving care from Brazil's Family Health Strategy. The FHS is Brazil's national health system, where multidisciplinary teams of a doctor, nurses, and health assistants provide free community-based primary health care, including comprehensive preventive and curative care. And the FHS decentralized and redistributed people with HIV from specialized healthcare clinics to a countrywide primary healthcare network to improve access, to reduce stigma, and to provide person-centered care. So now people with HIV in the FHS receive regular home visits by community health workers to monitor ART adherence, to provide access to other health and social services, referrals, and receive education and counseling. So what they found was that compared to areas with no FHS coverage, those areas with 100% FHS coverage had a lower incidence of AIDS and lower AIDS-related mortality. So I think the take-home here for all of us is that there is a large, robust evidence base to support HIV integration, including integration of HIV into primary health care services, and we don't need to wait for any more data. Thanks.
Thank you so much, Deborah. There is certainly plenty of evidence here, and I see a lot of opportunity for the global community to learn and adapt. It's really, really gratifying to know that integration can actually lower costs and lead to better health outcomes. Beatrice, from the community perspective, what needs to be done to close the gaps as we look towards 2030 and beyond? Beatrice, you are muted.
Thank you, Muka. And from the community perspective, one thing that would describe smart integration in this case would be a one-stop shop or one-stop center. And as a woman of reproductive age, smart integration means, what it means to me is that I should be able to access all the services that I need at that one point of care. But also at that point of care, does this healthcare system address all the social determinants of health? For example, it means that probably as a woman of reproductive age, I am struggling with emotional issues because of marital challenges. I am struggling being a woman, and again, our sources of income and coming off from a traditional society where we still rely more on the dominant male partner. Probably my economic status is not good, and I'm facing a lot of challenges with economics. So in that case, will the healthcare system be able to, for example, intervene and address my social and economic aspects? And again, is this healthcare system also able to healthcare system also able to help me to physically adapt to the infrastructure within the first health facility. What do I mean? We have women living with HIV who are women with disability. If the infrastructure does not support me, then it means that actually there is no inclusion. I am not welcome here. I have come for PMTCT services or ANC, then I am not able to, because probably the bed in the hospital does not cater for my specific need. So for us, it is the one-stop shop that can be able to address this. In terms of the social aspects, I'm facing GBV. Are you able to assess me for GBV? Are you able to offer me the referral that I need? Are you able to make sure that I actually meet that referral? So if I'm able to get those services at that one-stop shop, then we are good to go. At policy level, and I think this was highlighted by Yogan, at policy level, we need policies that will comprehensively address our healthcare needs. Do we have policies that can actually address my HIV needs, my TB needs? It will address my other sexual reproductive health needs? So at that level, are there lessons we can pick? I think we are not far from it. Within the HIV response, we have lessons we can pick from. For example, Uganda as a country has a very beautiful consolidated HIV guideline that speaks to some of these things in terms of policy. I am a woman living with HIV, TLD transition. Am I able to be assessed for NCDs? And after I am assessed, if I am at high risk, am I able to access the information, integrated information around NCDs? And am I able to accept the treatment at that point in time, given the information I'm provided? Again, at service delivery model would look at, I would want to spend lesser time at the facility, at the clinic. And spending lesser time would mean, can I access all these services that I need at that one-stop shop? So one thing we have noted through the community-led monitoring is that I come to the point of care, and here I have come for ARV collection, but perhaps because I am not feeling well, I need STI screening. At that point of care, I will be referred to the MCH clinic to get SRHR screening or STI screening at that point. That does not work for us. Am I able to get at that point in time that I'm not feeling well? Perhaps I have, and I present with symptoms with STI, and I get screened there and then for STIs within the ART clinic. And then that means that probably going to the STI, the MCH, saves me the time of probably when I get to the MCH, the maternal child health clinic, I do not have to make an additional queue where probably I am the 10th client. Yet at the HIV clinic, I was already at the front line and I could be attended within that particular time. Thank you.
Thank you so much, Beatrice. I'm definitely hearing from you that one-stop centers can be helpful for clients, but those one-stop centers have to be organized in a way that they look at the client in their entirety, looking at the whole person and the needs of that whole person and how they can be met at that single point in that visit. Thank you so much. Njeri, from a fellow implementer's perspective, what are the tools that are getting us closer to more integrated and person-centered services?
Muka, and thank you as well for inviting me to be a panelist on this very interesting webinar. So I think, a couple of things, the patient we're considering here, the patient is right at the center of everything. And we need to understand, are they being met at their point of need? And in order to be able to do that, then we need to look at, the healthcare workers and our health facilities. Are they ready? Are they prepared for, this patient-centered approach, patient-centric approach? And so, we need to identify there's some facilities who are already providing PCC services, whereas there are others who are slightly lagging behind, and they need to also be supported to move forward into be able to provide those patient-centric services in a more integrated integrated fashion as well as we speak about integrated services. And as we consider the overarching themes around, client-friendly services, responsive services, knowledgeable healthcare workers, the aspect of convenient services that we're speaking about, including extended opening hours, differentiated models of care where patients can receive their treatment, coupled with chronic medication so that they can receive not only their ARVs outside of the facility, but also say their mental health medication, their diabetic medication, their hypertensive medication, and also looking at the community and the stakeholders and community-led monitoring. So how then do we pull all this together and assess all these different aspects? So we need to put on that human-centered design approach aspect to it as well. And when we look at it, there are a couple of different tools I'll speak about. I mean, there's a plethora of tools out there, but I'll just touch on a few. So for instance, in South Africa, we've been talking more about the ideal clinic model, right? And this is basically a facility that has good infrastructure, adequate staff, adequate medicine and supplies, the laboratory systems, pharmaceuticals, all those components, the building blocks of health systems. And then there's also the integrated clinical services management. And this is where the health system strengthening model really comes strongly, and it builds on the strengths of the HIV program in order for us to be able to deliver that integrated care to patients. So when we're looking at the ideal clinic, right, whether it is in South Africa, whether it is in Malawi, Uganda, name it, Asia, there are a couple of components that are key, about 10 components that are key components. There's the administration, there's the integrated clinical services management, there's a medicine, supplies, and laboratory services. Human resources for health is critical. And as Deborah mentioned, it could be that you only have one nurse in a facility or one healthcare worker. So how then do we utilize them best? The support services, the existing infrastructure, your health information management systems, communication, your district health support systems, and your implementing partners and stakeholders. So those are the 10 basic components that are included, and there's about 33 subcomponents that would need to be assessed. But all of them, we look at an element of quality. It speaks to an element of quality and safety. And so the tools that are used to assess this framework is really then shaping that facility's performance against these different elements. The second way that we could analyze or assess these facilities is what we know as the SWOT analysis. And I think that one is, most people know about it, where we assess the strengths of the facilities. So when we put on our patient-centric focus and moving towards integrated services, what are the strengths of this facility? What are the data systems, again, in terms of looking at integration? What are the weaknesses of these facilities and the opportunities? So for instance, men's services, we know men want to have services rendered to them in their own sitting. So can we also provide integrated services for men in order then to be able to pull them into the facilities to get tested, to be initiated on treatment and retain them on care? And then lastly, and that is the threats. There are a couple of threats that we could think of. One, which was most recent, COVID. COVID threw everybody completely off balance. We were scrambling around. So what are we doing in terms of pandemic preparedness, even as we speak about integration of services and patient-centric care? There's other basic amenities such as water supplies and power outages. How is that affecting our facilities and our patients when they come to the facilities and there's no water and they need to use the ablution services or facilities? Then the last two that I'll just touch on is PROMs. This is a patient-reported outcome measures. So this leans more heavily on the patient and what the patient would like to see, the services they would like to receive. And there's still an aspect from the healthcare providers, because as a patient speaks of what they would like to see or how they would like their services and the outcomes thereof, then that also relates to the facilities and what the facilities can provide. Then there's also the JSI's person-centered care assessment tool. And this one is, quite exciting for us as well, but because it assesses also the capacity for the facilities to provide this patient-centered HIV care and treatment services. And this really also supports the facilities then to develop action plans in terms of where there are any gaps. Then the facilities can then develop action plans that are key and critical towards ensuring also patient retention. I think by the end of this, I'll probably sound like a broken record because I'll keep repeating patient retention in care, because at the end of it, in 2030, we still need to have those patients in our care and treatment services, even though as they continue to age. Thank you.
Thank you so much, Njeri. I think we can all relate to centering our care on the client, but understanding that there are elements at the provider, facility, and community levels that truly enable that person-centered care. And aspects of the health system then become really, really important. Speaking of person-centered care, we know that while integration is essential to meet community needs, we also must ensure integration into primary health care is done in a manner that preserves specialized care for people living with HIV, which speaks to Njeri's last comment about how we must ensure that we retain our clients in care. The choice manifesto for improving equitable access to HIV prevention, which was championed by ICW, was the first call to action. Beatrice, I have a two-part question for you, asking now for you to answer this question from the two hats that you wear. Firstly, coming from ICW, what elements do we need to consider to ensure equitable person-centered service delivery in integrated settings? Secondly, wearing your hat from your work with community-led monitoring initiatives, what is the community telling us we need to consider as we move forward with smart integration?
Thank you, Muka. So, firstly, looking at the first segment of the question, the program, the HIV program is the HIV program focuses on diverse populations, cultural backgrounds, socioeconomic backgrounds, and for us, where we are seated, communities we are working with, and in my own experience as a woman, sensitivity to diverse backgrounds, values, and beliefs is very, very critical. And therefore, what we expect from the healthcare system is equal treatment regardless of these different backgrounds, values, and beliefs. We are into about 4 decades of the HIV response as a country, and you will realize that stigma and discrimination is still a very critical barrier to access, and it's a barrier of inequality. And now when we talk about inequality, it speaks and resonates well with equal treatment regardless of where we stand. So for us to be able to do smart integration, it means that we need to address these barriers of access that specifically touch on our cultural backgrounds, economic backgrounds, the beliefs. We need to address them. And one of the ways that would be done would be looking at, for example, the training of the health workers that are one of the critical perpetrators of stigma and discrimination, for example. And I think as a response, nationally, globally, one of the investments that is being made is around training of health workers. And we do know that and appreciate that health workers' attitudes would go a long way in impacting some of these different backgrounds that we exist in. So it would be critical to continue such trainings. But also one thing that would change the narrative in the current setting would be that community-centeredness is very key. And therefore, for us to design a program that would look at addressing an attitude of a health worker that would, for example, help us address issues of stigma or the challenges that come with lack of sensitivity to the different backgrounds within which we exist, would be having consultation with communities at the design phase. As a woman, what is my experience in terms of attitude of health workers? And then it would go a long way to inform, for example, what are the critical things a training module would be looking into? Is it language you're using to address me when I come, for example, for PMTCT, and then I am being talked to that why would I indulge myself in getting pregnant in a time when I am living with HIV? So I think that would go a long way in terms of thinking through person-centered care, person-centered care. The other thing I would want to draw our attention to, again, is around providing integrated communication and education information and health services broadly, but also related services, especially when we talk about HIV or maybe other health programs and how they can actually integrate HIV. Information is a very critical aspect of utilization of services from my own experience and point of view as a client and a recipient of care. So when I do not have the accurate information or I'm not provided the information, it affects some of the aspects that Njeri was talking about. My outcomes. Will I perform well on ART? Will I interrupt? So for me, information is key. And relating this specifically to the Choice Manifesto, you realize one of the critical areas that the Choice Manifesto regarded as part of integration is ensuring that we integrate HIV prevention into existing information packages for other services. And for us, this was very key and pertinent. Why? You will realize over the historical implementation of HIV programs, especially where I come from as a community and also the clients that we interact with, the programs focus on yield, for example. Now, focusing on yield for a small program or for a program that is geared towards addressing new infections amongst adolescent girls and young women would do us a disservice. And what the community or the adolescent girls and young women are telling us is, as a young woman, I have predisposing factors, I have a lot of risk factors, I have a lot of challenges, and therefore, a HIV prevention program, say for example, such as the DREAMS program, where we have biomedical interventions such as HIV testing, would mean that test me not to find yield, but test me for prevention. And what does testing me for prevention mean? That you have tested me and I am HIV negative, but I should be able to receive comprehensive information around HIV prevention, and this includes the different choices that are available for me to be able to make informed choice. So why Choice Manifesto took that on as one of the critical areas is something that we believe in, and it is something we will continue as an institution to advance. The other thing I would want to highlight, especially in regard to the second segment of the question around what the community is telling us about smart integration. I earlier on talked about one-stop shop, but also as we implement a triple elimination strategy as a country, but also as global countries are involved in this. In the conversations now, a woman is telling me, I should get to a facility where adolescent girl and young women is telling me I should get to a facility where I have come for ANC. But as part of triple elimination, it means if I am being tested, then I should be tested for HIV, I should be tested for hepatitis B. And by virtue of the fact that I am pregnant and probably the children I am having, these are some of the critical areas and parameters and the data points we get from CLM, that an adolescent girl of the age between 19 to 21 at that age has 3 children and they're not having the same father. It means that they're at high risk. So what would this mean in terms of integration? That I should be able to get HIV testing, hepatitis B testing, and I should also be tested for other STIs such as syphilis. And therefore, in terms of smart integration, we do appreciate and know that they are the dual testing kits, but then it goes a long way to say that if we have different funding mechanisms, are we able to actually fund some of these triple interventions as one whole package? Are we able to have testing kits that could be able to test 1, 2, 3 of the diseases and be able to access those services at the one-stop shop I had highlighted earlier? Thank you, and over to you, Muka.
Thank you so much, Beatrice. It is critical that we preserve the quality of care and that we tap into the experience that clients are having, and we involve communities in our design Our clients have agency, lived experience, and they want to have choice and quality. And all those aspects you spoke about are really, really important. Thank you, Beatrice. Njeri, from the implementing partner and service delivery perspective, what are some of the elements we need to consider?
Thanks, Muka. Again, from a perspective of quality of care, and as you've spoken about the lived experiences of patients, their agency, and their choices, we need to take all these things into consideration. And one, again, going back to engaging with the healthcare providers, engaging with the patients and with the communities. And I touched a bit on the community-led monitoring initiatives that are there. I think those are some very interesting and really important perspectives that we need to bring more into the facility. Sometimes we don't like being called out on our shortcomings. And so we may get upset when we hear the communities is pointing out a couple of things that they're not happy about. But this only allows us then to improve the services that we are providing for the community. Because at the end of the day, we are not here to just do a job. We're here to provide a service. And so we need to provide it in a way that we're meeting the patients at their point of need. So again, identifying and addressing those gaps. And again, the key populations. What are we doing for our key populations? There's been a lot of stigma around key populations. And so are we able to provide key population-friendly services? If our facilities, our healthcare providers don't know what they're supposed to do, then we need to support them. We need to equip them so that they don't fall back onto what they're used to doing and ignoring what they don't know how to manage. So a couple of other things we need to consider is continuous monitoring. I spoke about the tools that we can use to identify how to support the facilities, but even when we implement these continuous improvement programs, then we need to also monitor them. And it's always best placed done with the Department of Health. Provision of training and mentorship for the facilities, and especially because of the changing guidelines. There's every couple of years guidelines change. So are the healthcare workers able to keep up with these changing guidelines? It could be one healthcare provider, and now we are adding on, diabetes management, hypertension management, mental health, assessment and management. So obviously guidelines change in order for them to keep up with that. Then there's the soft skills as well. And again, this is so essential to nurture and maintain those soft skills, because this is what makes the facilities conducive for the patients to keep wanting to come back. Years ago, when I was still a practicing clinician in an HIV clinic, my mantra every morning when I went to work is treat every patient as though they're my relative. I know we have some insufferable relatives, but majority of them, we get along with them. And so for me, that just kept me going, that I need to treat every patient as though they're my relative, because they're human, just like I am. And how would I want to be treated when I get to a facility? And just the last points around the laboratory systems. Are our laboratory systems equipped to conduct and collect specimens and to have good turnaround time so that the patients then again managed? You can imagine going to a facility, you're told that I need to take this test to see if you have meningitis. You don't even know what this meningitis means. You just came with a headache, and then say it takes 2 weeks before you get your result. What are we doing to support those facilities, those health systems strengthening, pharmaceutical services as well? Are our facility managers equipped to be able to ensure that they are monitoring the drug stocks so that we don't fall below a critical level of drug stocks, eventually to get to drug stock outs, right? And lastly, just continuous screening of the NCDs and ensuring that our facilities are integrating these, again, in a patient-centric, focused manner. Thanks, Muka.
Thank you so much, Njeri. I can echo that. We at JSI are also thinking a lot about the elements that are needed to support retention in care, especially as integration could lead to changes in the experience of our clients at the service delivery points. Supporting healthcare workers in that transition will help to preserve quality, the soft skills that are needed at the site of service delivery to make sure that the clients' experience is enhanced and they can be retained in care. And again, as you keep reminding us, health system strengthening, the lab, the supply chain, are those elements in place? And Yogan, on a macro level, what do you think we need to be thinking about?
Muka, thanks. I agree with everything that Beatrice said. She's a recipient of care. She knows and she's very clear about how she would like to receive care. And I think it's fairly obvious, I think, that we need to ensure that we listen to people who use the facilities, the users. We have in many parts of the world clinic committees to improve the governance, and we have clinic managers, but I don't think we spend a lot of time training clinic managers or primary healthcare managers. I think we train the clinicians in guidelines that Njeri just mentioned, and unfortunately they do change frequently. So, and this is the definition of integration by WHO as well. It's the management and delivery of health services for the entire continuum of care based on the needs of patients. So, if we return to that definition, it's fairly clear that we need to focus on management, clinical services, as well as patient voices. And therefore, co-designing the integration with the management, with the healthcare workers, as well as patients are critical. And I don't think we do that very, very well. Or what typically happens, and I'm not casting aspersions on anyone, is you'll have somebody providing technical assistance, going to a facility, and after getting some advice from somebody in the ministry, saying, well, we need to look at how we can help you integrate services. And I was as guilty as anybody else when I was in the Ministry of Health as the Deputy Director General. So I think a more bottom-up approach that fits the context, and we keep talking about the context, but Muka, quite frankly, I think we often talk about it rhetorically. We don't take it as seriously as we should. We're moving to more and more to simplification, and simplification is important for both providers as well as patients and users of the service. So I think we need to figure out how to simplify both not only access to services and provision of services, but also around self-care. There is no way we are going to have all the healthcare workers we need or all the money we need to provide people services at fixed facilities with a team of well-trained staff, with all the drugs we need and all the whatevers, right? That's never going to happen in sub-Saharan Africa in my lifetime. Let me not say in your lifetime, in my lifetime. So what is it that we need to do? We need to think differently about what we can do with existing resources. Coming up with blueprints, and I must say, things like the ideal clinic are good in theory. I'm not entirely sure that they work well in practice all the time. So my key points, adding to what Beatrice said, is let's simplify, let's co-design, let's focus on self-care, and let's focus on the assets we have, because we are not going to get significantly more assets anytime soon. And then the final point I want to make is, we did some modeling about what we likely to see with the HIV epidemic by 2050. And, this thing about, ending the HIV epidemic as a public health threat by 2030, is a bit of a misnomer. So we looked at, modeling out using the best information we have in the foundation. And in 2050 in sub-Saharan Africa, we will have somewhere around 26 to 30 million people living with HIV. And we will still have annually about 400,000 new infections by 2050. So we've got to, kind of also have that in mind. Even though we know we need to integrate, we know we need to do the integration smartly, there will be some people that would require specialist HIV care. I mean, we're still seeing in this part of the world significant numbers of patients presenting with advanced HIV disease, right? And that's obviously late presentation, low CD4 count at first initiation, and all the rest of the things. So, we've got to think about So where do we provide the so-called specialist HIV service? Is it at a district hospital? Is it at a tertiary hospital? Or can primary healthcare do it? If clearly they won't struggle to do it, but we need therefore good referral systems and referral systems at work. And therefore a more systems approach is what we require. Thanks, over.
Thank you so much, Yogan. You echo the other panelists on our need to focus on maintaining quality care and simplifying services for clients. You echoed the need to co-design to take into consideration the context. Simplification is what we need, and tap into self-care and tap into the assets that we have, because we are never, let me not say never, we will not have the ideal situation very soon, but perhaps we'll have it in the future. But for now, we tap into the assets that we have and fully utilize those. You also talked about the need for appropriate referral. Let me now segue to the health system. We focused on the requirements for service integration to meet evolving community needs as we shift towards a more person-centered and integrated care. However, we recognize that services don't simply occur on their own. They rely on robust data and information systems, versatile supply chains, clear policies and guidelines, and other foundational components of the health system to enable smooth person-centered care delivery. What system-level changes will be essential to support effective and smooth transition? And now talking about some of the concerns that perhaps Rose has elevated, that will I still get all the services I need when we have integrated HIV into the broader health system? So let me, that Beatrice talked about. Let me now start with our government leader, Rose. What would you say are the health systems changes we need to support effective and smooth transitioning?
So I echo what Yogan just explained, that we can have blueprints, like Malawi has a blueprint where we want to have HIV integrated within the broader health system. And this is what is in the health sector strategy plan. We have started co-designing what that will look like. So what that will look like may take us a year or 2 or 3, just to be able to integrate the M&E systems, the supply chain systems, all those pillars, the human resource. So for me as a lead in the HIV space, I think what we have said is, what is it that we can start now, which is the low-hanging fruit? Because then that will allow us to learn in the process as we are implementing a few components. So I'll give an example of integrating testing itself. So we are focusing on testing for HIV, syphilis, and hepatitis B as we want to eliminate mother-to-child transmission of those 3 conditions. So what we have done as a department is say, okay, let's have an integrated guideline for testing. Let's make sure that everybody that is providing services is able to test for those 3, not just for our pregnant women, but also even for key populations. Then we have also developed an integrated tool, which is AI generated, which is AI supported, which collects all that data. And we have moved a step forward to also use the same tool for PrEP. And we are also saying, but STIs and condoms and PrEP, they talk to each other. These are areas that we are already trying to integrate within the HIV program as we're waiting for all these system changes. But we have also started looking at the discussion. One discussion is, at primary health care, what are the cadres that are missing? And we have already done that assessment for us to provide a package of services that is important for both HIV prevention and care and treatment at primary level. which cadres are missing, and we have identified those cadres. And then we're also asking ourselves to say, okay, is the supply available? We have started engaging the supply people to make sure that these people are available. But also one aspect that we are seeing is, we have seen is, we are a low-income country. We cannot manage to be training everybody in all these, the so-called integrated package that will be delivered at the community. So what are we going to do? We have already defined the package needed at the primary level and community. So we are saying, okay, is there any opportunity for us to use continuing professional development? So we have invited the regulatory bodies, for example, for nurses, to say, is it possible that moving forward, yes, we'll train everybody in pre-service, but for its service, can you now enforce that everybody conducts a CPD in these priority interventions that we want everybody to have competencies and knowledge as they practice? So those are just some of the changes that we may need to make if we look at the HR component itself. What is it that is doable? What is it that is a low-hanging fruit we may focus on as we wait for the time when we are going to have everything integrated, all the supply chain and everything? So we are learning that it is doable, but it may take time. But also, I just want to focus on the use of digital tools, because if you are looking at integrating beyond HIV, whereby you have that client receiving care for NCDs in the same room, receiving family planning, and is at high risk, needs PrEP, what will the digital tools look like? We are already finding a solution for that, because now we can link our testing for syphilis, HIV, and hepatitis B. We have already started linking it with PrEP, with the injectable PrEP and the oral PrEP that we are offering. So we are reading that in the next phase, we are also going to incorporate STIs. So those are some of the low-hanging fruits before we even take all those big leaps to incorporate the other diseases, which are not solely under the mandate of somebody who is a program manager for HIV. We are already, everybody wants us to integrate with them because the resources are available in the HIV space. But also sometimes there's pulling each other because the malaria person would want something that maybe is not a priority for me. So for all of us to reach that stage where we agree, it takes time, but the low-hanging fruits are there. Can we start with them? And once we start, then probably we can incorporate these other needs. But it is important that when the client comes into that room, if they have family planning needs, they are provided. If they have malaria, they are provided, but we may not reach there immediately. So that's how I would want to respond. But the system areas have already been mentioned by a colleague, and I wouldn't want to repeat them, but I think it's a step, it's one step at a time, a phased manner. What works first before you go into the complicated areas? Thank you.
Thank you so much, Rose. It's great to hear how Malawi is clearly defining and structuring its policy framework to enable integration. But as you say, in a resource-limited setting, this is a give and take. It's going to take incremental change. We can't implement everything at once. So we look for the low-hanging fruit that will begin the steps for us to move forward. So thank you for that response. Yogan, your thoughts both in your current role and any perspective from your previous roles within South Africa's National Department of Health?
Thanks very much. Yeah, I'll just want to link to the kinds of things that Rose said. So, one thing I've been pondering about, if there's so much of evidence, and there is, on the utility benefit of integration, why are we struggling to do it and scale it, right? And it seems to me that there are a couple. One issue that Rose picked up already, and I'll start there, and that is the resources are unevenly distributed in the health system. And from where we sit with HIV, HIV has more resources in most sub-Saharan Africa countries as opposed to others. So that's the first. The second is that not everyone is convinced that integration is a good thing. Mm-hmm. So we need to do more work to communicate, the benefits of integration. Thirdly, I've heard from many healthcare workers while I was in the department, and still now that I've left the department, that they think integration does create more work for them. They'd rather sit and finish the HIV queue, and once that's done, they know they're done, right? So and that's a big part of it. And then finally, system change is tough. I think we've all experienced that. It's tough. It's not easy. And if it's not well sequenced, and this is, I think, what Rose was also pointing to, if it's not well sequenced, we'll get mired in the more difficult things and not do the things that are possible. So we need to be able to understand, what needs to be done and how to sequence things and how, of course, to take people along. And then, of course, using AI, LLM, etc., is critical. But we need to have connectivity in this part of the world. Connectivity is patchy and it's very expensive. So we need connectivity because we do need electronic medical records. And we need an electronic medical record that's affordable to countries in the region, including the maintenance of those systems. And then on the governance issue, we certainly don't have the kinds of accountability for providing good quality services. And I'm including South Africa there as well. When I was the DDG for health programs, if there was a maternal death, nobody held me accountable for that maternal death, right? And I didn't hold anybody accountable either. So accountability is a challenge. So the governance mechanisms, I think, are a challenge. And then, as I said before, Muka, we're not training our managers well, and we're not holding them accountable. And then the final point I want to make on systems changes is, usually the saying goes, she who pays the piper calls the tune, right?
Yeah.
Now we need to think about how services are funded. Is it on a capitation basis, which we're moving towards under UHC for primary healthcare? Are we still going to have fee for service, which I think most people agree is regressive and leads to all kinds of perverse incentives in the system? So we've got to think about, can we use finances? And I know we've discussed performance-based financing and the rest of it, but can we use in a different form under UHC the way we finance primary healthcare to get the integration we're looking for? Is that a lever that we might benefit from, as we think about it? Thanks. I'll stop there. Thank you.
Thank you so much, Yogan. I think you touch on a number of things building on what Rose said, that resources are unevenly distributed. So how do we think about financing our push towards integrated service delivery? You talk about governance mechanisms and accountability. And I think what you are pointing out today, that when we equip the health system, we sometimes forget to train the managers. And that is an important link. I think that's really, really important. Deborah, let me come to you. How is USAID thinking about the system changes needed and how we support national and local governments in this area?
Thank you, Muka. I think the first piece of this for USAID is that maintaining high quality HIV testing, treatment, prevention services is essential, and integrated care should help us engage those hard to reach populations and improve HIV outcomes. So integration is a means to this end. Building off of some of Yogan's comments, HRH funding flexibility is something that we're thinking a lot about. Funding and training healthcare workers to care not for a specific disease, but for holistic person-centered care, which means untangling the way we pay for human resources from the way that we monitor HIV programs. So envision, instead of a completely parallel staffing structure where HIV-funded staff perform HIV care and government-funded staff perform primary care, we adjust the funding model and cross-train the entire staff to provide HIV and primary health care. So people with and without HIV would receive primary health care and HIV services in the same place from the same staff. Staff are integrated, salaries are aligned, healthcare workers are now more flexible and efficient, and all staff are incentivized to provide HIV care, which allows us to sustain HIV progress, close HIV gaps. So that's the first thing. I'd also put in there rethinking how we collect data to monitor programs we need to resist the temptation to collect more data than is required to do the job, because data reporting requirements impose a real financial burden and strain on our partners and programs. Data collection on HIV and primary healthcare services should inform national data systems, and then governments can share this data with donors and other stakeholders. This avoids costly, time-consuming parallel healthcare reporting and ensures quality across disease silos. And also reducing these data reporting requirements for implementing HIV integration will promote funds to free up for additional training, quality assurance monitoring, et cetera. Electronic medical records and HIV results reporting also need to be aligned with the general health system and then expanded to serve other primary healthcare services using this digital platform. I think the last thing I would say, and Rose spoke to this as well, the backbone for a sustainable primary healthcare system is a well-defined, well-supported, multidisciplinary health workforce in the facility and in the community. We know that community health workers improve community access to primary healthcare and HIV services, multi-disease health screenings, linkages to referral systems, incorporating community participation, but often community health workers are not integrated into formal healthcare worker cadres. They're frequently underpaid, understaffed, and under-equipped. So I think we need to think about how to coordinate investments in policy and systems to support community health workers and to strengthen institutional capacity for overall healthcare worker management to promote healthcare worker safety, retention, and quality. Thanks.
Thank you so much, Deborah. You mentioned health workforce support as well as some other areas of focus, especially around funding and financing complexities, both around human resources, making sure that when we train our our providers, we train them in person-centered care so that they can provide for the entire needs of the client when they are providing care to the client. On the data front, you talked about national ownership of data and reporting, but not imposing more data burden at the level of collecting the data we need to make the informed decisions we need. One of the strategies that we have found at JSI for accelerating the transition to nationally owned data and reporting systems is making targeted improvement at the subnational level. For example, upgrading subsystems that manage various patient-level data, including HIV data, and then making them fully interoperable, providing an enduring solution that better aligns with national systems. Overall, I'm hearing from our panelists, and I would agree, that government leadership is non-negotiable to successful integration across the various elements of the health system, from human resources, information systems to supply chain and health policy. And around health policy, the issue of the community health worker and how the community health worker is onboarded as a part of the health system and therefore part of the establishment that the health system supports. Before we close the panel discussion, I want to invite our panelists to share a final reflection with us. How do we approach person-centered integration in a manner that protects our progress towards epidemic control and meets the needs of our clients, while also contributing to long-term sustainability? 2 minutes each. I'll start with you, Rose.
Thank you very much. I did mention about the consideration for M&E tools, and I was trying to explain what Malawi is working on in terms of so what we have done is to come up with priority interventions. What are the priority interventions that are value for money, that will be impactful? And those are aligned to performance indicators, because by 2030 and beyond, we want to sustain the gains and focus on the key indicators that are very important. I think that is one area which we may also need to consider when it comes to integration, because we may end up integrating and focusing on interventions that may not give us the results, the SDG 3 in 2030 and even beyond. For our people living with HIV, we know what works, we know which indicators we need to focus on. Those are the areas that we should also align with the package of interventions, with the competences, with the demand creation or the health promotion messages and all that. So I think there are a lot of considerations that will be needed, but it's important to focus on what is impactful and also monitor the performance of the key indicators which are aligned to the interventions. I think I would want to say that as one critical area of focus or reflection.
Thank you so much, Rose. Beatrice, what are your final thoughts in 2 minutes?
Thank you, Muka. So for us to have smart integration, community engagement in conversations of integration is very, very critical and key. And for us, one of the key things that we should be emphasizing as part of community engagement is that engagement that enhances community ownership, community local leadership, and then community empowerment. And specifically in line with community empowerment, we should be able to have an understanding of our rights and responsibilities if we are able to, or if we are to ensure that we are able to accept and utilize the services that were being offered. Thank you, and over to you.
Thank you so much, Beatrice. Njeri?
Thanks, Muka. I think I'll close with 2 broad points. The first is a retention in care. As I mentioned, I'll sound like a broken record. Retention in care is a crucial and critical component for long-term well-being of our patients. And because we know when they cycle in and out of care, we're at risk of losing them to a myriad of conditions, including OIs and, as Jorgen mentioned, advanced HIV disease, artery resistance, amongst others. And coupled with this is that growing mental health concern. So we need to just ensure that in as much as there's multi-morbidities that our patients will be experiencing as they age and perhaps start getting new NCDs, they'll also have multi-medications. However, that should not equate to multiple visits to a facility. Second point is, assess, analyze the situation, identify the opportunities. We've said, it's context related, leverage on the best practices, because the best practices are there across the different countries, across the globe. Implement tailored, co-created solutions without necessarily reinventing the wheel. Because the goal at the end of the day is what we're talking about, integration of services with a patient-centered care focus in order to maintain retention in care. So just lastly, there's a Chinese proverb that says that the best time to plant a tree was 20 years ago, and the next best time is now. So with integration of services and with a patient-centered focus, we need to jump onto that opportunity in order for us to implement those services tailored for our patients, listen to what our patients are telling us, and ensure that we do it that way. So let us remember not to forget that the next best time is now, so that in 2030 and beyond, we'll look back, and as Jorgen said, we'll be able to say we did something right when we started having these conversations. Thank you.
Thank you so much, Njeri. Jorgen, your final 2 minutes.
Thanks, thanks, Muka. No, I agree with all the speakers who spoke to this issue. I just want to add one thing, and that is, we've forgotten about the district health system, that primary healthcare occurs within a system, right? And at least in Africa, we've been promoting the district health system. And within the district health system, I think the key issue is around managing the system and ensuring that all the pillars, the foundational pillars of the system are in place, including clinical support from the district hospital, management support from the district office, to facilities, so that we think of the primary healthcare and person-centered integration within this system. If we don't, I think we run the risk of fragmenting services at the district level. So we've got to think about the role of the district hospital as well as part of integration and person-centered integration. Thanks. I will stop there. Thank you very much.
Thank you so much, Jorgen. Deborah, your final thoughts.
Thanks. I'll close with 2 things. The first, I know Beatrice and Njeri and others have discussed this in part. So Community engagement is critical for these sustainable HIV services and integration. Local communities, civil society organizations need to be involved in designing integrated programs and ongoing community-based monitoring to ensure quality. That's the first thing. And the second thing, this speaks a bit to Yogan's bottom-up approach that he was talking about earlier. I think we need to empower our partners to define pardon me, context-specific integration models and to reorganize service delivery to fit at community and facility levels. USAID has compiled a lot of these examples, successful HIV integration into primary healthcare that our partners are already implementing at site level, facility level in Kenya, Zambia, Tanzania, Uganda, and elsewhere. And all of these models are showing reduced interruptions in care and improved viral load suppression since they started integration. And what we found has made these models successful, this is what our partners are telling us, is that when health center leadership faced with staffing problems, coverage gaps, workload imbalances between HIV and non-HIV staff, long wait times, HIV stigma, when they were empowered to make bold changes in the way they train staff and the way they deliver services within their facilities so that they can find hard-to-reach populations for services and close their HIV gaps, they were able to create these innovative models. They were cost neutral, and they were able to look at their staffing outcomes and HIV outcomes and use a CQI approach to further refine and adapt the model, and then continue refining and adapting until they were pleased with, how things were working for them in their contexts. I think as donors, we can do more to encourage this kind of innovation. Thanks.
Thank you so much, Deborah, and thank you to our panel of experts. You all touched on critical considerations as we move ahead, including community engagement, person-centered service delivery that enables retention and care, training managers in HIV integration and into primary care, context-specific integration, building towards long-term sustainability of the HIV response. We have about a minute for one question. We'll take a question from Tabiso Ngwe, who works as a data capturer at a clinic where they're also involved in health education and supporting youth-friendly services. And they say that I'm passionate about integrating technology and person-centered care to improve access to healthcare, particularly for HIV-positive individuals. And the question is to you, Deborah. What are some examples of innovative person-centered integration practices you've seen in USAID-supported programs?
Sure, thanks so much, Tabiso. And I put this answer in the chat, and I'll just summarize it here. There are a lot of innovations we've seen that extend innovations from the HIV service delivery realm towards the broader population, towards primary healthcare. And I listed a couple, like coupling appointment systems for HIV visits with other, not just NCD visits, but family health visits, bringing your children in for care at the same time that you get your comprehensive primary healthcare. Utilizing innovations like facility-based fast track dispensing, community-based differentiated drug delivery, not just for ART and other chronic disease meds, but also for PrEP and family planning, and doing this with multi-months dispensing quantities, and also integrating community services and community support groups for people with HIV and NCDs, because the management model for these diseases is now so similar. The education, the adherence, the ongoing requirements to stay in care, the support we provide for clients really can be merged in many areas. Thanks.
Thank you so much, Deborah. We've received a number of questions in the chat and in the Q&A, and as we share the recording from this webinar, we will share some of the responses from the panelists. Unfortunately, we have very little time. Do we have time for one more question? Perhaps we have time for one more question. Beatrice, the community already offers testing and counseling and some counseling services and some DSD. In point of view of the community, which other services can be integrated on communities to address the needs of people living with HIV? I think this is about how we can make sure that we continue to address the needs of people living with HIV and are careful to make sure that those services continue to be available. Again, going to what Njeri was talking about making sure that we retain people in care and we continue providing quality HIV. So Beatrice, just some of your thoughts about the service mix and what can be done as we integrate HIV to continue meeting the needs of people living with HIV.
So
Definitely.
in line with integration of services into the community, I would want to express this using an example of the differentiated service delivery models. So countries broadly and Uganda itself is implementing the differentiated service delivery models. And one of such models includes the community drug distribution points or the community retail pharmacies. And as a recipient of care, integrated services in the community would mean beyond coming to me to give me a HIV test, I should be able to receive on-site psychosocial support and counseling that is very comprehensive. I should be able to be, currently we are linking people on care, provided we have the qualified healthcare professionals that are going to these community models. We should be able to link, for example, someone on care. But if the person is already on care, then we should be able to offer additional services. And I think this was highlighted again by Yogan, that I am in the community, you have come to the drug distribution point. I should be able to be assessed if I'm not feeling well, having fevers, I should be assessed for malaria by that one community health worker. If I am having an STI, I should be able to be assessed at that point of care, at that point. And then where the service cannot be handled in the community, I should be able to be linked through the appropriate referral pathways to access healthcare at a facility, which should also be following the principles of integration that we have all discussed through this call. Thank you, and over to you.
Thank you so much, Beatrice, for that comprehensive answer. And I hate to close such a lively discussion, but we are nearing the end of our time today. And I would like to take a few minutes to share some of the key takeaways. We learned from Deborah that there is a growing body of evidence that supports the careful and strategic integration of HIV services into other health areas, demonstrating significant benefits for both individuals and systems. Integration leverages shared resources, enhances accessibility, and addresses the interconnected needs of people and communities, making it a cost-effective and sustainable strategy for strengthening the overall health system. Rose discussed how integrating HIV services into primary care requires thoughtful and context-specific approaches to ensure sustainability, including greater national ownership of data and reporting, the health workforce, and other elements of the HIV system that have been siloed from broader national healthcare systems, but emphasizing that incremental progress is what's going to make it work for us in resource-limited settings. Yogan walked us through the essential health systems requirements for success, including a strong health workforce, availability of health commodities, outreach services, and innovative technologies to simplify service provision, but also emphasizing that there are other aspects beyond the health system that will facilitate this integration. He mentioned particularly connectivity and the requirements for connectivity and other broader economic considerations that will support this integration. We have power outages in a lot of parts of Africa. How does that affect integration? He urged that contextual factors, including the maturity of the health system, epidemiological patterns, and the socio-political environment, must guide and inform our integration efforts. As Njeri said, a one-size-fits-all approach risks undermining the tailored interventions that HIV programs have historically relied upon. Instead, integration should be smart, leveraging synergies with other health services while preserving the distinct elements that address the specific needs of people living with HIV. We have to think about how we are going to retain people living with HIV in care for the long term. Yogan mentioned 2050, and he said that there will be millions of people who are living with HIV, and we must consider how we retain them in care for the long term. Beatrice strongly cautioned against the fallacy of the empty vessel, reminding us that our clients have a say in their own care. She advised that by actively engaging diverse stakeholders at every stage, we can design integration models that are context-specific, equitable, and sustainable while preserving the gains made in the HIV response. I want to extend my sincere gratitude to the panel, Rose, Deborah, Yogan, Beatrice, and Njeri. Thank you for taking the time to sit with us today to discuss these issues and chart a path forward. It has truly been an honor. Thank you so much. And many thanks to all of you who joined us for this discussion. We appreciate your time, questions, and attention. Please sign up for our newsletter for announcements about future webinars. Thank you, everyone. Goodbye.
Thanks. Bye, everyone.
Thanks. Bye, everyone.